Hello, everybody. My name is Tobias Zuchelli. I'm a gastroenterologist at Henry Ford Hospital in Detroit, Michigan, and I specialize in therapeutic endoscopy.
Hi everyone, my name is Yervant Ichkhanian. I'm one of the GI fellows at the Indiana University. Thank you for joining us. We will be presenting our study under the title Endoscopic Ultrasound Guided Drainage of Intra-Abdominal Abscess using 15 millimeter versus 10 millimeter lumen-apposing metal stent, an international case match study.
Thank you, Yervant, and thank you all for joining us today. Let's begin with the background. Yervant, why was this study conducted?
So intra-abdominal abscesses, often a result of surgical complication, have traditionally been managed with percutaneous drainage and antibiotics. While that an effective option and it is less invasive relatively to surgery, its effectiveness is sometimes limited by factors such as the location of the abscess, as well as the discomfort and the catheter obstruction that often leads to failures as high as 35%. Surgical drainage, as I said, although effective, it is associated with higher morbidity and mortality. And this is where the endoscopic or endoscopic ultrasound approach has offered a minimally invasive alternative. Lumen-apposing metal stents have been used with increasing success, especially the newer electrocautery enhanced designs. These stents allow better drainage due to their larger diameter and anti-migratory features. However, the ideal size 10 versus 15 millimeter for the intra-abdominal abscess hadn't been well studied, and that was the primary aim of our research. Therefore, we studied retrospectively using a multi-center approach and included patients who underwent EUS-guided drainage for intra-abdominal abscesses between March 2019 and September 2022.
Thank you, Yervant. How did you group these patients?
So we divided the cohort into cases and controls. The patient who underwent drainage with 15 millimeter lamps were designated as cases, and the ones with 10 millimeter were designated as controls. They were matched by the abscess etiology, location, and drainage approach. We assessed both technical success, this was defined by the successful stent placement, and clinical success, which was defined as the radiographic resolution of the abscess.
Were adverse events tracked?
Yes, we did track the adverse events, and they were classified according to the agreed criteria to stratify their severities. And the number of procedures needed for the resolution of the abscess was also documented.
Nice. What did your findings show?
So very briefly, we had a cohort of 51 patients, 29 in the control group, 15 millimeter LAMS group, and 22 in the case group, which were the 10 millimeter group. Both had similar baseline characteristics, including the age, sex, comorbidities, and the abscess size. In our study, the most common location of the abscess were peripancreatic, seen around 40% of the cases and controls. This was followed by perigastric, perihepatic, perirectal, and perisplenic regions in the descending frequency. The great majority, or 88% of these abscesses, were post-operative, often following procedures like Whipple, Billroth II, distal pancreatectomy, and cholecystectomy. We found that the median time of diagnosis was around 3.4 weeks post-surgery. As for the size of the collection, they were fairly comparable between the case and the control group, around 80 millimeter in diameter. The median time from abscess diagnosis to EUS-guided drainage was around 9 days. The technical success was achieved in 97% in the case group and 100% in the control group, and the clinical success was achieved in 98% in the case group and 96% in the control group. Both outcomes were not statistically significant. More than half, or 53% of the patient, had a plastic stent placed for the maintenance of the fistula after the LAMS was removed. But importantly, we did not observe any abscess recurrence among patients who achieved clinical success. While the success rate were not significantly different, there was a noteworthy finding. Patients with 15 millimeter stent required fewer total procedures, 2.5 versus 3.6 on average, which was statistically significant with a p-value of less than 0.02.
It was really great to work with you on this project. And as you know, this is our multi-center study that looked at the safety and effectiveness of US-guided intra-abdominal abscess drainage using 10 versus 15 millimeter lumen-apposing metal stents. And the reason we kind of started this project is there's uncertainty about what aperture would be best at resolving these abscesses, 10 millimeters with the lamps or a 15 millimeter lamps, because when you drain an abscess, it tends to be filled with a thick purulent debris that doesn't readily drain. So we wanted to limit the risk of recurrence. We wanted to resolve these abscesses, and that's what we studied through this paper. Our clinical success rates were really about the same between the 15 millimeter and the 10 millimeter group. There was a clinical trend towards better outcomes in the 15 millimeter group, which could translate to better patient comfort and cost effectiveness.
One question that might be of an interest to the reviewers is, what are the factors that you take into consideration when deploying the lamps in terms of choosing the size and the window and the approach of the procedure?
Yeah, great question, Yervant, and probably the most important question. We really start first with patient safety. And really, when we look into this, we want to ensure that we're doing a multidisciplinary discussion. We want to engage the surgeons, the interventional radiologists who may be involved in this case, or any other team that may be involved, to make sure we're doing the next best step and the safest step for the patient. Then you want to know, where is your window for drainage? Is it from the stomach? Is it from the duodenum? Is it from the colon? Based on those clinical parameters and figuring out the estimated size of the abscess you want to drain, you want to kind of select out your 10 versus your 15 millimeter lumen-apposing stent, because each size is going to have a different range of deployment and different tips and tricks to make sure that you're deploying these stents safely into the abscess and avoiding adverse events.
Yeah. Thank you so much for the important points. And lastly, we just wanted to mention that our study did have some limitations, including the retrospective design and the variability of the institutional practices, given that it was a multi-center study. And obviously, future prospective studies are needed to refine the stent selection and define the best optimal population that could benefit from this procedure, as well as the post-procedural management.
To wrap things up, thank you all for joining us today. I'd like to personally thank all the centers that were involved in the study that we participated in. And I'd like to thank you, Yervant, for doing a stellar job. And I hope everybody enjoys the article.
Thank you for mentoring the project. Thank you, everyone.